welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shamagam. In the past 30 years, rheumatology has made enormous progress, but there are still many areas where outcomes seem to lag behind the research. One of those is in managing patients with lupus, and in particular, the management of pregnancy in patients with lupus. The manuscript we will discuss today is Systemic Lupus Erythematosus Delivery Outcomes are Unchanged Across 3 Decades, recently published in ACR Open Rheumatology. A link to the manuscript and disclosures are in our show notes from today. I'm excited to be joined by the first author of the manuscript, Dr. April Bernardo. Dr. Bernardo is an assistant professor of medicine at the Vanderbilt University Medical Center, and she has appointments both in the Department of Medicine and the Department of Biomedical Informatics. Her research focuses on using data from the electronic health record to study and evaluate outcomes in patients with systemic lupus erythematosus. And she's currently funded by an R01 from NIAMS, focused on predicting the risk of systemic autoimmune disease in patients with positive anti-nuclear antibodies. Welcome to the show, April.
Thank you for the introduction and for having me. I'm excited to participate in my first podcast discussing my research.
So the work you present in this manuscript was actually completed some time ago through your K08 award, which investigated using electronic health records to stratify risk in patients with lupus. I wonder whether you could set the scene by telling us more about your K08 project and how you combined your interest in bioinformatics with your expertise in rheumatology.
Absolutely. So my K08 award from NIAMS focused on how we can repurpose the electronic health record as a research tool to better understand disease heterogeneity in lupus and restratify patients. The K08 really relied on phenotyping lupus individuals and outcomes in the EHR and biomedical informatics techniques like phenome-wide association studies or PheWAS and phenotype risk scores to subphenotype or subgroup lupus individuals. My interest in biomedical informatics really came out of necessity. When I first started my first faculty position, I moved to an institution that didn't have a senior lupus person or a prospective lupus cohort, and I had an interest in clinical research and outcomes research in lupus. I didn't yet have funding, so I had to find a cost and time efficient way to kind of pursue those interests. I had to pivot somewhat with help from a mentor and met 2 faculty members in biomedical informatics who introduced me to this concept of having an electronic health record-based cohort or virtual cohort. And I was fortunate to be at an institution, Vanderbilt in Nashville, Tennessee, with one of the world's largest biomedical informatics departments and also robust and unique resources available.
And so looking at this particular outcome of pregnancy in patients with lupus, there was a little bit of prior work that had kind of informed this study. Could you fill us in on some of those background studies? I think there was a previous study through the National Inpatient Sample Dataset. Can you tell us about that work and why your research team still felt there was a knowledge gap that needed to be addressed?
Sure. So really prior lupus pregnancy studies have used a traditional prospective cohort model where lupus patients that are followed in a rheumatology clinic are recruited for a study, or population-based studies that mainly come from European countries. And then there are also administrative or insurance database studies like the National Inpatient Sample Dataset that you mentioned. And typically the administrative database studies typically use only one billing code for lupus to identify those individuals and pregnancies, but they really lack kind of granular data on the lupus disease course. And as I mentioned, my research interest has really been in using a lupus EHR-based cohort. And to date, there really haven't been many EHR-based studies or ones that really, we thought that EHR-based studies could complement these other type of studies, the prospective cohorts, the administrative databases. They would allow for a large sample of lupus pregnancies. They would have a diverse population of patients that may not participate traditionally in research studies, and they would have longitudinal and then granular data on not only lupus, but other comorbidities. So we thought the EHR-based cohort approach would really complement kind of these other studies that have been done looking at lupus pregnancy outcomes.
And so you used this Vanderbilt-based data set called the synthetic derivative in your study. Can you tell our listeners what that is and why did you feel that was very well positioned to answer the research questions?
Sure. So the synthetic derivative is a mirror image of the electronic health record. It's de identified. It has over 3.6 million individuals and counting. It has longitudinal clinical data from the late 1980s to present. It contains all clinical data, so billing codes, inpatient and outpatient notes, laboratory studies, medication. And with its longitudinal data, we were well positioned to assess maternal and fetal outcomes in our lupus pregnancies over that 30-year span.
We'll get into that a little bit further in a second. Tell us first, how did you define your lupus cases and your controls? And how did you deal with mothers who both had multiple pregnancies and then mothers who had pregnancies with multiples?
Sure. So we identified potential lupus deliveries using a validated and published algorithm that we had developed that requires at least 4 or more lupus ICD-9 or ICD-10 billing codes, along with at least one validated delivery related code. So for all potential lupus deliveries that were identified by this algorithm, we performed chart review to ensure the patient had a lupus diagnosis by either an internal Vanderbilt or external rheumatologist. And then the chart review also allowed us to determine the timing of the delivery in relation to the lupus diagnosis. Controls were also from the same data source, the synthetic derivative, but they did not have ICD-9 or 10 billing codes for systemic autoimmune diseases, including lupus, rheumatoid arthritis, Sjogren's, for example. And we also require the controls to have longitudinal care at Vanderbilt and then use the same delivery-related billing codes we use to identify the lupus deliveries for the control deliveries. We then randomly selected 250 of those controls for chart review to ensure they didn't have autoimmune disease and then to assess the delivery outcomes. So since both lupus and control mothers could contribute multiple pregnancies, and since we know parity can impact pregnancy outcomes, we did conduct some additional sensitivity analyses in which we only analyzed the first pregnancy if there were multiple pregnancies. And then for modeling, we also constructed a generalized estimating equation, or a GEE, to account for the correlation between kind of multiple pregnancies per patient.
And did you have any pregnancies that involved multiples, as in twins or triplets?
It was a very small proportion of our overall sample, but yes, we had a few of those, and they were each, the sample size or the N for the study was the delivery and not the mother for a lot of the analyses.
Yeah. And just to clarify for our listeners, because, I think many people kind of don't fully understand this chart review that you conducted was a more manual process, right? So you had the kind of pulling of the data from the EHR, but then subsequently went back and manually reviewed charts to confirm that the controls didn't have lupus and that the lupus patients did have lupus. Is that correct?
Yes, that's correct.
Yeah. So quite involved and quite a lot of work. Tell us about the outcomes that you were measuring and how did you define them?
Sure. So we used an OBGYN diagnosis of preeclampsia and eclampsia that was documented in the notes. For this study, we focused on deliveries defined as gestations 20 weeks or more. And then we used pretty standard definitions for other outcomes, such as preterm delivery, a live birth with a gestation less than 30 weeks, miscarriage as fetal demise less than 20 weeks, for example.
Tell us, I guess, first, you looked at the lupus pregnancies and the control pregnancies. What did you find in terms of differences between those two groups?
So yes, comparing the lupus and control pregnancies, we found a similar mean age at delivery. The control mothers had a higher number of pregnancies and deliveries. Live birth rates were similar in these two groups. We did observe higher rates of C-section, preterm delivery, preeclampsia, and preterm preeclampsia, all in the lupus pregnancies compared to the control pregnancy. So really increased adverse outcomes kind of across the board in the lupus pregnancies compared to the control pregnancies.
You, I think, were asked by one of the reviewers to do an additional analysis that looked at comparing the outcomes in your data set with some of the historical cohorts. Can you tell us a bit about that analysis and what did it reveal?
Sure. So We performed this analysis too to compare outcomes kind of using, again, our EHR-based cohort approach to outcomes that had been seen in these more traditional prospective lupus cohort studies. And so adverse pregnancy outcomes, particularly preterm delivery, was higher in our EHR-based study with preterm delivery at 51% in our study and around 30% in other prospective lupus cohort studies.
And one of the other things you looked at was women who were diagnosed with lupus but had had a prior pregnancy and had data in your data set. And you looked at the pregnancy outcomes in those women before and after their lupus diagnosis. Can you tell us what you found in those pregnancies before the patients were diagnosed with lupus and then comparing that with their outcomes after?
Sure. So we compared 60 lupus pregnancies that occurred before lupus diagnosis to 178 pregnancies that occurred after lupus diagnosis, and surprisingly found similar rates of adverse pregnancy outcomes, including similar rates of preterm deliveries and preeclampsia. And interestingly, I found similar results of this increased adverse pregnancy outcomes in pregnancies that occurred before lupus diagnosis in a prior study that used a predominantly African American lupus cohort. So I wonder if there is a preclinical disease state in lupus that maybe negatively impacts these outcomes.
Yeah. And I feel like actually that's something I always used to teach medical students, that the OBGYNs were far more likely to identify our diseases than we were to have a patient be diagnosed with pregnancy. So I feel like making friends with your OBGYNs is always really important as a rheumatologist. One of the other really unique features of your data set is that it allows you to analyze medication use and to do that in a longitudinal fashion. This is very complex analysis. And I wondered if you could tell us some of the findings that you found regarding medication utilization in the pregnant patients with lupus and how that's changed over time.
Sure. So, in addition to the cross-sectional analysis, we perform longitudinal analyses of prescribing patterns for lupus medication use from 1989 to 2020. And again, these are in pregnancies that occurred after a lupus diagnosis. So we found that corticosteroid prescribing rates remained pretty consistent over that study period and were fairly high at 60 to 70%. Hydroxychloroquine prescribing during pregnancy did increase over time, but really only peaked at around 70% in 2015. Aspirin use or aspirin prescribing decreased over time, with most recent rates in 2015 and 2020 very low at only 20%. I also want to highlight that we performed some longitudinal analyses of pregnancy outcomes as well in both the lupus and control pregnancies. For the lupus pregnancies, we found really that adverse pregnancy outcomes with a focus on preterm delivery and preeclampsia really remained stable over time. So really didn't improve over that 30-year study period.
Which is a sad truth, I think. I'm going to cycle back to some of those medication findings because I do think it's really interesting, in particular in regards to steroid use, which seems really high in this cohort. Did you have any thoughts as to why that might be?
Sure. So one hypothesis and kind of what I've seen other providers do is that, right, there's the concern that we need to stop all medications when a patient is pregnant, right? That's kind of the practice we just see for any kind of medication, right? Trying to be risk averse and not wanting to be on medications during pregnancy. And so I think a lot of patients with lupus get their hydroxychloroquine stopped or other medications that are safe in pregnancy. And so then the patient then flares, right, being off those medications and needs prednisone to help manage those symptoms that emerge when you remove medications from the patient's regimen.
Yeah. And to clarify, these patients were all being managed in a tertiary care setting, right? These are not community settings. And so, even in this expert center, people are not necessarily always taking the medications that are recommended. In regards to the aspirin, do you think some of that was just underreporting, or do you think that really the aspirin use was that low?
So certainly we do worry that the lower rates could be impacted by underreporting. You don't have to physically order or prescribe aspirin, right? It's over the counter. But talking with our maternal fetal medicine OBGYN colleagues and how their notes look, they very systematically collect that data in their notes. And also, we looked at kind of admission notes, both from anesthesia and OB when these patients would get admitted for deliveries or antenatal care. And both of those types of notes pretty systematically asked and collected that information. So might have lost some, but our kind of colleagues in maternal fetal medicine didn't think we missed very many because of the way that data is collected in their notes.
Yeah, interesting. So actually, that kind of gives me a nice segue into my next question, which was really the limitations of this study. And as someone with biomedical informatics background, I wondered whether you could speak to the limitations of these large longitudinal data sets. And in particular, you can use them to answer these very broad, far-reaching questions, but they do have some limitations as we use them. And I wondered if you could kind of delve into those a little bit for our listeners.
Sure. So we had several limitations, including using data from a single center tertiary referral center that could bias our results to have more severe outcomes. With using de-identified EHR data, we don't have available data on education level, income, insurance status, and we know these are important social determinants that impact pregnancy outcomes. We also do not have lupus disease activity like SLEDAI or damage scores, as these aren't routinely collected as part of clinical care. And then certainly there's missingness in EHR data due to the fragmented healthcare system we have in the US. So records from outside our institution are not always available.
Mm-hmm. And I guess, your data going back into the late 1980s, I mean, that was the early days of EHR. So I'm assuming some of that early data was more limited, right? And as time has gone by, our EHRs have become so much more robust. I'm guessing that's kind of a challenge with integrating some of this data over time.
Sure. Some of the older data certainly is more kind of dictated letters and notes, not the kind of templated notes that we see with newer, more modern EHR systems.
Yeah. So I'm sure you've spent many, many, many hours at nights and weekends doing pulls of data kind of manually from some of these records. And there's something to be said for that, but it is a more laborious way to pull out information.
Sure, yes.
So I want to pivot now and talk a little bit about your career. You have trained at some of the country's best institutions for rheumatology training. You completed your medical degree at Emory. You did internal medicine residency at Duke and then fellowship at Medical University of South Carolina before transitioning to this physician scientist career pathway at Vanderbilt. I wondered if you could share with our listeners some of your experience on that journey. What did you gain by moving through those different institutions? Who were the mentors who helped you along the way? And in particular, what attracted you to Tennessee?
Sure. So I've moved around a bit due to having a spouse who's also in academic medicine. I certainly fell in love with rheumatology and clinical research in lupus, with having strong mentors along the way. First in medical school with Sam Lim at Emory, Megan Close at Duke, Diane Kamen, Gary Gilkison at MUSC. With coming to Vanderbilt as a newly graduated fellow, I certainly faced some challenges with wanting to continue to pursue that interest in clinical research and outcomes research in lupus. As I previously mentioned, when I arrived, there wasn't a lupus person or established lupus cohort, so I did have to pivot a bit. I was very fortunate to have a strong career mentor at Vanderbilt, Leslie Crawford, who connected me with strong biomedical informatics mentors who had access to these strong resources that we have at Vanderbilt. And really, the collegiality and these people and resources have kept me at Vanderbilt in Tennessee.
Yeah. And Leslie definitely has recruited over the years some of the best and brightest in the field of rheumatology to Vanderbilt. So I feel like that is a kind of legacy that she has brought to the institution of these, amazing up and coming scientists, and has figured out how to kind of nurture and help them build their careers. And you're now about 9 years, I think, into your faculty position. You've completed a master's in clinical investigation. You've successfully transitioned from a K Award to an R01, which is no small feat. And one of the features of K Awards is that they include this period of training and mentorship. Can you share with our listeners what you've learned along the way?
Sure. So finding strong mentors who support and advocate for you is key. Even if they're not experts in your area of research, I learned quickly you can have different types of mentors, ones that maybe are experts in your disease area focus, maybe they're methodology experts like my biomedical informatics mentors, or career mentors like Leslie, who are really leaders in the field and have a proven track record of trainees who are successful in academics. And I've been fortunate to have Leslie Crawford as a career mentor for the past 9 years. Other lessons I would add to having strong mentorship would be, be prepared to face rejection and failure and realize you may have to change directions. Engage with other researchers outside your division or department and use their expertise to think creatively about solving problems in your area of research. I certainly am grateful for my partnerships with experts in biomedical informatics and biostatistics, and know their contributions have only made my research more rigorous and impactful.
I thank you so much for saying that, because I think, so many of us are a little bit afraid of failure, but failure is really how you learn. It's your first attempt at learning, I guess, if you want to play on those words. And, I think it's been famously said that you don't lose, you either win or you learn. And so, I think it is really important as a junior researcher to learn to embrace those disappointments and figure out how to use those experiences to transition your career in different ways. So, April, your current research is really focusing on an issue that's eluded rheumatologists for years. And specifically, how do you predict the risk of developing autoimmune disease in a patient with a positive ANA? I'm wondering, I know it's early in the course of this research, but are you able to share with us anything about that work?
Sure. So we're currently submitting these results as abstracts to the upcoming ACR meeting and for publication. Briefly, we've assembled a cohort of over 2,000 patients with a positive ANA from the synthetic derivative data source that I've talked about before, and using that data for both a training and validation set to validate a risk model that predicts risk of having a systemic autoimmune disease in individuals that have a positive ANA. Some of our preliminary findings are our model includes predictors that are readily available in the EHR, including demographics, billing codes that capture signs and symptoms for multiple systemic autoimmune diseases, and then laboratory studies. Our initial logistic regression risk model had a good AUC of 0.83, and we've seen some good calibration with that model and some good internal validation.
So we're looking forward to hearing more then from the upcoming ACR meeting, and hopefully you'll be able to enlighten us as to, how to predict risk in that group of patients that I think, every rheumatologist in the country is following. I want to draw back in, I guess, the kind of characteristics of some of these projects that you've been involved in really involve these large biomedical teams of researchers. Can you tell us how over the years you've learned to bring people together to study these fundamental problems in rheumatology? And do you have any tips for early career researchers trying to build a team?
So for the ANA risk model work that I gave a little preview about, that certainly has been an example of a team effort. At Vanderbilt, we have this group called AVAIL. It's Advanced Vanderbilt Artificial Intelligence Laboratory, and it really brings together experts in biostats that help build and validate the risk models, biomedical informatics experts who partner with health IT to pull data from the EHR, clinical informatics experts who assist with deploying the risk model and informing best practices for implementation, decision support, and then lastly, hospital leadership, administration, and nursing. So really, these are team efforts with multiple parties with different backgrounds. I think, embracing the expertise and the knowledge that each member of the team brings helps you think, again, more creatively, robustly about your research, and certainly, I think, makes it more relatable, allows you to deploy it to actually help improve patient outcomes ultimately.
Yeah, no, I think it's so important. And it's nice to hear that your institution has so kind of wholeheartedly embraced the importance of that. I think that really will set set you all up for success. Do you personally have any tips for people who are kind of considering a physician scientist career pathway? What do you wish you'd known when you graduated from fellowship and began your first faculty position?
Sure. So I repeat it, but I think it's so important. I'm going to repeat it again. I think really key to success, again, when starting that first faculty position is having a strong mentor who advocates for you in your division, your department. Also having protected time early on in your career to actually build your program, write manuscripts and grants. It can be really challenging as a physician scientist, right, to juggle clinical duties. And so having that protected time, I think, is critical to advancing your research program. What I wish I would have known, I think I had a false notion early in my career that your career path and your research efforts had to be kind of linear. And I would listen to senior scientists discuss their journey, and they seem to have this very clear step-by-step roadmap. And I quickly learned that it's much messier than that. And in the real world, there's roadblocks and detours. And so you may not end up where you think you will. I certainly and at a place where I hadn't envisioned when I first started. But I think those detours and failures and really help you learn a lot to make you stronger, more resilient as a researcher, and then just make your science more impactful.
Yeah, I think that's such good advice. And I'm really thankful to you, April, for sharing that insight. Thank you for all of your insights and for joining us on the show. I enjoyed hearing about your research. I'm excited to hear the results of your studies being presented. And I thank you so much for being so candid in sharing some of your experiences.
Thank you, Vicki. Thank you for having me.
So in this episode, I also want to give special thanks to the funding agencies who take a chance on our junior physician scientists, investing in their careers and setting them up for success. It is exciting to see studies like this focused on answering real-world research questions that impact patient care come to fruition and also support the careers of our junior scientists. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Room on social media and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.